Now I have the pleasure and the honor to introduce the lovely and talented Dr. Shalini Nayar, who is currently practicing as both a respirologist and palliative medicine specialist in British Columbia at the Surrey Memorial Hospital and the BC Cancer Agency. She attended McMaster University for her internal medicine training and subsequently completed the respirology fellowship at the University of British Columbia, UBC, as well. Dr. Nayar is currently functioning in the capacity of local department head, acute palliative care program for Surrey Acute, and is a clinical assistant professor with UBC Department of Medicine. Geez, Dr. Nayar, what don't you do?
Lots of things.
Lots of things. Her interests, presentations, and publications have focused on the importance of palliative care interventions in both malignant and non-malignant diseases. Please help me welcome Dr. Shalini Nayar.
So I'm really grateful to be here today. So I'm one of the doctors that Fran was talking about who love doing this conference every year. And unfortunately, last year I was on a screen, so I may have met some of you on the computer, which was horrible. So I'm glad to be able to be here in person. I'm also grateful for the suggestion to talk about mental health, which, as we just heard, is an extremely important part of any person's journey with any illness ever, but particularly in lung diseases as a whole and pulmonary fibrosis. So today I'm hoping that we talk about that we talk about the two most common forms of mental health issues that people develop when they have chronic illness. One is depression, one is anxiety. It's important to be able to recognize when those things are happening, why those things are happening, how you can recognize them happening at all, and then decide together what on earth you do about it when these things are found. Can it get better? And the short answer is probably yes, right? There are a few general indicators of people who develop mental health, and most of them have to do with disability, whether it's progressive or acute. The older all of us get, the more likely it is that we are vulnerable to the development of any mental health illness at all. People who are less supported, either with friends or with family, are at increased risk. There's no decanting of any of the stressors. Individuals on multiple different medications, what we don't pick up a lot is that a lot of the side effects of these medications can induce mood disorder, either uppers or lowers or withdrawal, right? So it's a spectrum, so we can't miss those things, especially as we get older and get on more medications, of course. There are people that have a genetic predisposition, so you'll see that there are clusters of conditions or traits within a family. Some of it is situational with how you're raised together as a group, and some of it isn't. It has to do with neurotransmitters and some of the science between why we get these mental health vulnerabilities to begin with. A lot of the times there are no risk factors, but there's a stressful event, a trigger, that gets somebody to feel like they're unraveling. And so even with one major event, it can have repercussions for a very long time. So these are the general indicators that we should be thinking about. Depression itself is a mood disorder, okay? And I think most people will view depression as sad, down, listless. It can be a lot of things, actually. It's an adjustment problem, right? And it's how we react to the adjustment. But sometimes we can't control that. When it gets out of our control, then we call that a clinical condition, right? So mood disorders are formally diagnosed by clinicians, by doctors or other healthcare professionals, based on specific criteria in a big book called the DSM-5, right? So that's what we're looking at when we receive a person who feels like they may have clinical depression. But what a person is actually feeling that triggers us to go through that diagnosis is generally low mood, low for them. So you can be an extremely fit, happy person, going out and exercising every day, and change that exercise to 1 day a week. You come to see me and I say, well, it's great. You're exercising 1 day a week. But if I speak to your family members or the people that know you well, they'll say, this is a huge difference. He used to exercise 7 days a week and can only manage to go and do it once. So it's relative and subjective to what a person is individually like at baseline. It's a difference in them. We know that people feel that it impairs their performance. Again, individualized. Whether that's going to exercise, doing your art, going to school, being able to get to work, those things start to fade away and become less important, and you may even stop doing them altogether, okay? They may have changes in appetite or weight, so that's weight gain or weight loss, significant increase in appetite or significant decrease in appetite, but a change from a person's baseline. Sleeping may become an issue, so either too much sleep that's inappropriate that they wouldn't usually do, or awake all night, just can't seem to sleep, or even a disrupted sleep-wake cycle, awake all night, sleeping all day, but just a change in pattern. Trouble concentrating and poor memory are one of the things that we often don't pick up enough, especially as age increases. I think there's a certain subset of the population that believes like, oh, I'm getting older, I forget things. I can't concentrate on doing that anymore. I can't stand. But if that change is happening quickly, right, it may be treatable, right? We may be able to fix that if it is also associated with some of the other things that you're feeling that I've mentioned above. The most important one, I think, that most people display and usually is the most difficult to diagnose is the loss of interest. Listless. We call anhedonia. Yeah, I mean, I could go to the movies like I used to, I just don't feel like it today. And that feel like it today becomes don't feel like it for a year, right? And why should we miss out on the things that we would like to do? So that's a general overscope. So those DSM-5 criteria, I don't think we should memorize them, right? But they do, the most important part of them is that you have a mood problem for longer than 2 weeks, period, right? That it's pervasive, persistent, it's either low mood or sad, angry, irritable. So you have to have had a mood problem for a little longer than 2 weeks, plus any 4 of the other clinical symptoms that I mentioned. That's what I would be looking at. Now, physicians would take that a little bit further, so that's what a person would present with. What I am looking for when I am screening any of my patients is whether it's actually impairing them. Is it interfering with your quality of life and your ability to do things? That, to me, my red flag ringer goes up and says, that is clinical depression. That is something that should be treated and intervened on. It's not something that this person will just probably get over, right? I'll also look at whether or not the episode is accounted for by another illness, hypothyroidism, steroid problems. Is there any other explanation other than mood disorder that I could possibly be missing, right? So that's part of appropriate screening. Do you have another psychiatric disorder that has depression as a side effect of having that disorder? For example, schizophrenia. Patients with schizophrenia or bipolar illness may cycle through different feelings and different moods, and it doesn't mean they only have depression. It means that there's a wider problem that needs to be treated, and then no episode of substance abuse. So that's also quite relevant. So if somebody is using alcohol, depressants, sometimes even cannabis, right? And I will say that with a caveat, not everybody gets a psychiatric mood problem from the use of cannabis. I have recommended it in very many patients before, but it is one of the side effects of that type of medication, okay? But if you look beside it, lung disease in general overlaps significantly with symptoms of depression at baseline. So if you have a diagnosis of advanced pulmonary fibrosis, you may feel fatigued because of the illness. You may have appetite changes because of the illness. These are difficult to tease apart and why it might be so easily missed in advanced lung disease, right? Anxiety is the other big one, okay? And I will relate both depression and anxiety specifically to pulmonary fibrosis in a minute. I just want to make sure we're on the same page of what we're talking about, right? So anxiety and fear are sisters, but they are completely distinct, right? And I think people may sometimes think anxiety is apprehension, right? It kind of is, because the difference between fear and anxiety is that fear is an uncontrolled, immediate reaction to a stressful or scary event. It's also brief. It goes away once that inciting event has gone away. Anxiety is more cognitive. It's slower. You start to think about things in anticipation of something fearful happening that maybe sort of hasn't happened yet, or already happened and now you're worried it's going to happen again, right? When you activate fear at the wrong time, that immense, scary emotion, that's panic attack. That is fear-driven, but not really an appropriate trigger found, okay? That's how we define a panic attack. And if you don't address the persistent anxiety-type thoughts, those may lump together, become ways of thinking and loop feedback, right? And become a generalized anxiety disorder. And so that's why it's really important to recognize symptoms of anxiety first. There's also the DSM-5 big book criteria for anxiety, okay? And so the difference is that anxiety-type symptoms need to be present for greater than 6 months, which seems a long time to worry, doesn't it? But that's how hard it is to distinguish, am I just worried about my test, right? Versus, is this an inappropriate anticipatory worry and there's nothing really to worry about, I just worry, right? So you have to be either restless, agitated, irritable, or have sleep disturbances to be categorized in general anxiety disorder. But what's really important is the picture on the right there, which is what the person will be feeling, okay? And that is always a prolonged course of excessive anxiety and worry. They may get muscle aches because they're so tense all the time, right? They don't change position very often, or they sit in the same spot and just think about things over and over and over again, which isn't like a common position that any of us would ever choose to be in. They may be really irritable, again with the difficulty sleeping, and they may be fatigued as well. So depression and anxiety have several overlap features. So sometimes we treat both at the same time if we think that they're both present. So how does this relate to interstitial lung disease or pulmonary fibrosis? It relates extremely strongly. And that's why I'm so glad to be able to talk about this enormous topic today, to start it anyways, right? Because we can look at several studies that have looked directly at health-related quality of life, how people are feeling. Now, these are mainly what we call observational studies. So they're not a big scientific randomized control trial. And a lot of the work I do can't be. How can you randomize people to have anxiety or depression and then look back on it? So all we can rely on is patient and caregiver experience, which is an extremely powerful history, to be honest. They use multiple scales in these studies, okay? There are scales upon scales to measure anxiety and depression and health-related quality of life. They all matter, but what's important is to know that they're different even in the country that you live in. There are 3 themes that emerge in all of them together if you pool all their data. The first is that poorer quality of life is associated with clinical anxiety, that which I went through the criteria with you for. So true anxiety is present 30 to 60% of the time. That is significant, wholly significant. And that depression, same criteria that I talked about when we talked about the depression slide, is 50 to 57%, which is weird, above 60% of the time as well, which is also hugely significant, right? And we do know that both of those things, mental health problems with anxiety and depression, are worse as breathlessness gets worse. So that we can extrapolate that the more advanced stages of illness, we should be screening more aggressively and watching our loved ones and ourselves more aggressively, because it's more than likely we may develop issues with mental health. So what on earth are the themes of what they're scared about or anxious about? What are people thinking about? And this is specifically in the pulmonary fibrosis ILD cohort, okay? So 2 themes arose. So one is fear of progression. The other is perception of illness, okay? And the fear of progression, there's no clear data that it's better when you take antifibrotic therapy, just so you know. So there may not be any mental health effects on using antifibrotic therapy. uncertain prognostication. How do I know when things will change? There's no scale, right, that actually is meaningful in pulmonary fibrosis that tell us how long any individual, right? It's so individualized. Each person is going to be different, right? And then worrying about the people you love. And then the perception part. Does what I think about my illness equal what my doctor thinks about my illness? Does so-and-so down the street think I'm catching with my illness? There's so many perception factors that are individually varying. These are the most common themes that came out in these studies. Other themes that came out, and this is specific to the patients with pulmonary fibrosis, but could be extracted to patients with other lung diseases. If you have a higher financial strain, it's worse. If you have suffering from pain, it's worse. You should be screened. If you have any other disease associated with fibrosis, it's worse. If you go to hospital a lot or have to go to hospital a lot, it's worse. If you are more disabled, we should be screening you closer. And if you have low social contact, we should be doing our darndest to find ways that you get more. It's impactful to be diagnosed with a mental health issue when you have patients with chronic lung disease. Reduced overall quality of life, family relationships strain, right? That irritability or the low mood can make others around you feel bad, not that you intend that, but also they may feel bad because they can't help you and they don't know how because it hasn't been identified appropriately. So we need to be able to call it what we think it is. It clearly affects health-related decision-making and compliance. I find that concerning, and I think everybody should, right? That if a person isn't thinking clearly because they have negative ways of thinking, that they're more likely to be less compliant with their medical therapy and more likely not to put increased thought into the decisions that they're making about their future. And it's a two-way street. Chronic illness and depression exacerbate each other. Okay, and that is the take-home message. It's hard to diagnose it, and that's because we need to screen for it, and there are no wonderful screens that are integrated in like practice. So if I see a person who's just had a hospitalization and they're sad, I'm going to think that's situational. It's sad right now, but maybe they'll feel better. The ball gets dropped when there's no follow-up to that. Hey, did it get better? Right? It's okay to have situational depression or anxiety. Everybody has that. That's called living, I think, right? But not everybody has to face it every single day for 6 months or more. No. There's significant overlap, as I showed in the earlier slide, between baseline lung disease and these mental health issues like fatigue or loss of mobility or listlessness that can happen in advanced stages of disease. So we need to be able to ask the questions to people to say, hey, how are you feeling? We need to screen for other issues that could be contributing, problems with our glands, our thyroid disease. How often are all of us being screened for those things? When somebody thinks you have a chronic illness on one side, they may not be looking at all the regular things you could also be getting, so it needs to be thorough. A lot of the medications we use in this room have side effects. Anybody who's been on prednisone, right, knows that you get a mood problem sometimes, right? Irritability changes, appetite changes, you become insomniacs, and then you take away the steroids and then you get depression, right? These are symptoms of withdrawal. So we need to be sure we're screening for medication side effects as well. And then us in the healthcare profession, not my responsibility. It's everybody's responsibility, right? And unfortunately, we've placed that onus very, very squarely on the shoulders of yourselves and your loved ones to tell us, when really we should also be asking, because I kind of feel like we're at the stage with mental health that all of us should know better. This is Mr. Shortness of Breath. I laughed at my own joke. I realize that's why I'm laughing, because I meant shortness of breath. So this is an example of a gentleman who's 68, recent diagnosis of pulmonary fibrosis, on antifibrotic therapy, hospitalized for the first time, 5 days of an inpatient, brutal in any hospital, gets home, finally released from hospital, having had this new treatment, and his family's like, yes, let's have a celebratory dinner. And he says, I really don't want to. Show of hands, who thinks he might be depressed? Yeah? So it was less than 2 weeks. He could be depressed, but this is the exact patient I'm talking about that, yes, I ask you today, do you think he's depressed? We say, maybe, maybe not. There needs to be follow-up. Because what's interesting about him is he does have fatigue and apathy, which may be because he was hospitalized. Hello, who's not tired after they've been in hospital in bed for 5 days? And they started steroids. So maybe he's irritable. Maybe he's not sleeping well. So to start, this is what we would say is situational, but that's not where it should end, is what I'm suggesting. But all of us, anybody who's had the flu, right, has been through this. You feel horrible when you're trying to get better even, right? So he needs a formal assessment at some point. He needs follow-up. Who should he talk to? A doctor or a nurse practitioner. Any one of us should be able to at least steer you in the right direction, okay? I am not a psychiatrist. I am a lung doctor. But if you came to me and told me that you were worried that either your loved one or yourself weren't feeling yourself, I would take the time to explore what not feeling like yourself even means. And if I don't feel comfortable, I know that I can refer to either a local mental health group in the community, a psychiatrist that I know, or back to your family doctor, depending upon how mild or severe the symptoms are presenting themselves. I know where to go. So tell whoever you trust, but say something, but we should also be screening. It's the flip side. How do you treat it? Cognitive behavioral therapy, medications, and pulmonary rehab, which I was so happy to see. Pulmonary rehab in fibrosis patients has excellent reductions in mental health issues, which is wonderful. So briefly, again, it's a huge topic to condense in 20 minutes. I apologize. I can't elaborate on the treatments because I learned so much about them while I was doing this talk, actually, putting it together. But essentially, I would view CBT as psychotherapy, behavioral, and thoughts modification. You have to be trained in this sort of technique to do it well. Every mental health unit in the community will have the ability to offer you CBT, okay? The wait list in the community may be long. You can private pay a psychologist, and there are some psychiatrists that will incorporate CBT into their practice. Many do not, so I would just caution you there that if you're looking for CBT therapy, just be sure that the practitioner is supportive. I would recommend this as a potential first step or for anybody with mild symptoms who maybe didn't want to be on medications or had a history of not doing well on medications, right? This is sort of a mind over matter, trying to take back what you can control. Medication choices are huge and robust. There are at least 6 different classes of antidepressive medications that I will not bore you to tears by describing to you, but I will let you know that of all the medications studied in naturalized medicine, psychiatric medications have amongst the most robust and highest level of evidence. They are very well controlled. Nobody wants to feel like they have to take them all the time, but geez, if it's recommended that you take them, they have shown excellent efficacy, like the highest order of efficacy for anything we can treat in medicine. So despite the stigma, they are efficacious, okay? The reason why there's so many is to avoid drug interactions with different medications and side effects, which may include, drowsiness when you first start them. So there's a robust amount of them, so we can try different ones. And then the pulmonary rehabilitation piece, I was so pleased. So there were actually a few studies looking at pulmonary rehabilitation in patients with COPD, which actually showed the reduced depressive scores. So mental health really did measurably improve, which I'm extrapolating for pulmonary fibrosis because the teaching is the same. You all go to the same courses, right? But in ILD patients in specifics, the overall health-related quality of life, including mental health issues, was improved. And of course, fear lessens with education. You don't know what you don't know. And if somebody tells you things that you didn't know, you feel empowered. And of course, the benefit of exercise is well studied in improving mood disorders. So pulmonary rehabilitation for all those reasons is so important. So in conclusion, because it needs to fit in the time, there's a significant overlap between your symptoms of lung disease itself and mental health changes. identifying and treating them does alleviate some of the downside of having any mental health issues. So the earlier we can recognize and treat, the better outcomes all of you have and the better decisions you make for your medical care. We need further research into screening tools for healthcare providers, like what are the 5 quick hits that my patient can answer even in the conversation with me or even before you see me, that I can email you? What questionnaire that actually works, that isn't 30 items long that you'll actually have time to fill out, right? Because right now the onus, I recognize, is on you. That's hard. I will happily take any questions from anybody if you have any, and I appreciate your time. Thank you so much for having me here.
From my own experience, it's on. Hello. From my own experience, basically, pre and even post, it's frustration. Pre, because I couldn't do the same things anymore. I was being hampered by oxygen and what have you. Mm-hmm. But I quickly learned to adapt to that. I golfed with oxygen on until I couldn't, until I had to use too much. The concentrator couldn't keep up. So, and post, it could be age and what have you, along with 10 years now being on the anti-rejection drugs and so on. Mm-hmm. It's just frustration at little things I can't do anymore. Mm-hmm. But it's not, to me, that's not depression. That's just, or it could be, I don't know.
No, I think you're right. I think it's situational frustration, or it's just that it's so frequently happening that it begins to lump together. However, if that begins to interfere in your life, because it sounds like the opposite, and you, sir, it sounds like you pushed through and did the things you wanted to do despite having those frustrations. The opposite is true for mental health illness, that the frustrations would stop you from doing those things, right? So that's the first, I think, red flag item, right? But the second is, if those negative thoughts did start bothering you, right, if you wished for more positive thinking, CBT would be wonderful, because that's something you can do to sort of change the inside the loop feedback, that more negative thoughts beget more negative thoughts beget more negative thoughts. You can break that.
The only other observation was with the support groups pre-transplant, was from people not in the Lower Mainland, that they're told they have to come to Vancouver for 3 months. How can they afford that? How can they rent a place down here? Who's going to look after their home, wherever it is, Terrace, Kelowna, Cranbrook, wherever? And then they're making a life decision. Do I really want a transplant? Can I afford a transplant? I saw a lot of that prior to.
That is an excellent point. And I don't know if you guys saw the newspaper article that was out, I think it was last year, where somebody who was on the island had said, I am literally not choosing a lung transplant because we can't afford to, and my family can't be uprooted. That is a huge, ridiculous, right, medical decision. And those are exact examples. And of course, given your experience, very astute and specific examples that matter, because we have long since known that. And you're right. And I don't have any suggestions to make it better personally. I wish I did. I have no power. I'm this little lady. But I do agree.
Well, just another point on that. BC Lung helps out with that now. There's a process to help people who are financially unable to, and it's through the social worker in the transplant group who makes that decision, and then they're in contact with BC Lung, and there's some financial help given. It may not.
That's everything.
Yeah.
That's everything.
Helps them out a little bit.
Yeah.
I have to interrupt.
Yeah.
We've got the hotel calling us. There's all the people who have parked downstairs have put their names at the desk for the license plates. There's a car about to be towed. CXE A780. No? Beats me. car. The last three are 780. No? Okay. Sorry, okay, here you go.
No, that's
I
great. Thank
apologize.
you, everybody. I appreciate your time.